Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, and welcome back. This is Unraveled. I'm David Kaufman, and I am here with my friend and colleague and conversationalist.
Hello, Eileen Ruhoy.
Okay, so today we are going to do another session or episode answering a series of questions that somebody posed, which are really, really good. All things about antivirals. What's the expression? All things? Everything there? I don't know.
There's an expression about viruses?
No, there's this phrase, all things. Anyhow, we're going to talk about
all things
antiviral
viruses.
drugs. All things viruses. Okay. So there's a series of questions, but I'm going to add a starting question, which is, why are we even having this conversation? Why is it relevant to discuss viruses in the context of MECFS, long COVID? And
let me say that I sort of
patients?
prompted that we do this because I actually wanted to hear your answers to the questions.
Sure.
Because the longer I do this work, the more I realize how important our exposure to viruses are to our overall health and long-term health, right? So, you know, when I was young, or even when I was a younger doctor practicing, it was this idea that you were exposed to a virus, you got some sort of cold or gastrointestinal illness or some acute viral illness, and then you got better and it was done with. You know, and as we've talked about, I think in a previous episode, in neurology, there are some post-infectious neurological disorders, but they're usually very fairly post-infectious, where you ask the patient, have you been recently sick? And they would say, yes, last week I had a viral illness, I had a cold, you know, something like that. It was never sort of seen as anything that was long-term, certainly never anything that could be delayed in terms of its onset. And all of that was wrong, because that's what we see in these chronic and complex patients. And so I have now been like, I want to learn more about viruses. I want to understand more about viruses. And of course, every virus seems to hold its own treasure trove of
treasure trove of trouble. TTT.
Ooh,
like that.
I like that. That's
TTT.
the name of our book, Treasure Trove of Trouble. I really like that. Nobody steal it.
So I could go off on a long tangent, which is virus and evolution. You know, how did we get here and how many viruses are integrated into our DNA? But I'm not going to go down that road, although it's totally fascinating.
It is
one of the most exciting and interesting parts of medicine.
100%.
Evolutionary biology.
Right. The fact that viruses can change our genome alone just fascinates me. And which just means that our genome is changing every day, right? Because we're always exposed. And then, of course, this whole idea of latency and dormancy and then reactivation, I'm just constantly amazed by it and just want to learn more. So when I saw these questions on our page, I thought this was sort of a good, you know, inroad to more of a conversation about viruses.
So why relevant to our patient population? So it's pretty well established that roughly 2/3 of MECFS patients have an initiating event with a viral infection, almost always an EBV, Epstein-Barr virus, causing mono, okay? So that makes it pretty relevant. 2/3 is a lot of patients, okay? And clearly long COVID is a viral infection, and built into this issue with the initiating or precipitating event is this whole concept of reactivation. So when we say 2/3 of MECFS patients, in fact, many of those patients don't recall ever having mono, all right? But they, like 90% of the population, have EBV infection they acquired as children, okay? So the real question is, how come I don't have MECFS, but my patients do, even though we both have EBV? And I don't have a great answer for that. I don't think anybody does. It's probably genetics, genetics, other changes in the person's immune system, because the key concept here for all of these infections that we're talking about in the herpes family, that's eight herpes family viruses, is that we acquire many of them as children. So HSV1, cold sores, CMV, cytomegalovirus, HHV6, EBV, HHV7. Pretty much we all get those as kids, okay? Our immune system cannot kill them. They are immortal until we die, Okay.
Wait, are you suggesting that mononucleosis, which usually happens in high school, college years ages, is a reactivation of the EBV?
No, actually, one of the theories of why mono is more associated with ME/CFS is that those people didn't get EBV infected as children. They get it as an adult, and they have a much more intense reaction. It's like mumps. In the old,
Or chicken
people
pox?
don't get mumps and chickenpox
I
these
had
days.
chickenpox
But
when
if
I
you
was
get it as an
15.
adult, it is really bad. It's not.
So I did
just-
not know that, actually. I just learned something new.
Right. So it's probably a more intense immune response, kind of like COVID in a sense. You have this cytokine storm. So if you've ever known somebody who had mumps or chickenpox as an adult, it is brutal. Okay.
No, I had the chickenpox as a 15-year-old, which isn't
Well, I'm
necessarily
sure
an
it was
adult, but
unpleasant.
it was incredibly unpleasant.
right.
I had them everywhere, and I still have scars from them.
So but the concept, I want to drive this home. So we get these
You don't
viruses.
care about my scars?
We get these viruses. Our immune system controls them, and the control function, so to speak, is basically they put them in jail. They just lock them up. They make them latent or inactive or hibernate. Choose your colloquial word you want to use. And they are generally hiding in cells. And EBV, as a classic example, is latent inside our B cells. Our B cells are what make antibodies. So it's pretty smart. They're hiding inside the army, right? It's a Trojan horse in a sense. Okay. So anytime these viruses can reactivate, break out of jail, and replicate and cause trouble at any time. And that time is usually defined by an alteration in the person's immune system, either by other illness, intercurrent illness, steroids, high-dose steroids, chemotherapy, cancer, trauma, emotional stress. Think about how many times people get cold sore breakouts because they go to the dentist. The dentist didn't cause it. It's the trauma of the drilling and the futzing around in there. How many times? And, another example is shingles. Shingles is chickenpox virus reactivating later in life. That's the classic example. And it reactivates often at times of stress, right? Or when the immune system is declining, which is what happens when people get older, which is why shingles is more common in people over 60, or other infections. Okay. So that's sort of setting the stage. Why does it matter? It also matters, obviously, from what you said before. Viruses are everywhere. They are part of our life on planet Earth, and they've been part of the life on planet Earth from the beginning, and they're a big deal. Okay.
Yeah, and they're now being found to be associated with several neurodegenerative diseases.
Right,
So
right. The more we look, the more we find. I mean,
Right.
EBV and MS is a nice, sad, classic example.
Yes.
Okay. All right. So in terms of the first question on this list was, how do you choose the antiviral? Before I answer that, again, I want to move on to one other thing. I think a critical study was done in 2013 by Dr. Montoya at Stanford, Jose Montoya, in ME/CFS patients. And he studied, a small study, but placebo-controlled, 30 patients. And he selected patients who had elevated antibody titers or levels. And antibodies are made by the B cells in response to infection. And the concept or the theory was patients with high antibody levels of HHV6 or EBV, it implied they had reactivation of those viruses, and that was the cause of their illness. That was the hypothesis. And he gave them either placebo or valganciclovir, Valcite, and titers went down. There was changes in the blood counts, in the white blood cells, certain white blood cells, and the patients felt better. And there was a significant difference in terms of measuring fatigue levels and performance levels and global response levels. So that kind of got things going. So when the first question you need to think about when you see these patients is, how do you determine if they have reactivation? In other words, I don't give every patient who comes in an antiviral.
Mm-hmm.
I will try to first determine if there's evidence enough of a virus that's reactivated that would justify giving them.
How do you
antiviral.
determine that?
Right. Well, that's a tough question. Okay.
I'm sure.
So generally, I do serology, antibody levels on everybody, for all the major herpes family viruses. And as I just said, most people already have infections, so there will be elevations in those antibodies. So how do you tweak out who has enough evidence of reactivation? And it's not easy. It's a very gray area, and certainly what I'm going to say is subject to criticism because there's no great study. Okay, so in medicine in general, very often decisions about infection are made based on antibody levels, even though we all know that is a really crappy indicator, all right? Because it's a lagging or a leading indicator in the sense that it's the B cells making antibodies in response to the infection, but those antibodies may have been there for 9 years, 6 months, 3 days. There's no way to know. It's very hard. So some of the evidence or some of the numbers I use is if the levels of the quantitative levels of the antibodies are more elevated than we would think is reasonable. And I'll give an example. So let me think of some numbers that will work for people. So we'll use EBV. So EBV has, unlike some of the other infectious organisms and viruses, we have 3 antibodies we can look at for EBV in the IgG class. Okay, I'm not going to give the names of the initials, but there's VCA, EBNA, and early antigen. Those are IgG, and then there's an IgM. Okay, so in any patient, unless they recently were brand new sick, IgM should always be negative. If the IgM is positive, that's already a big signal to me. And then in these 3, you would expect the levels to be low. There's a range. I'm going to make up the numbers just for the sake of this. Let's say the range is 200 to 1,000. Okay, so anything below 200 is negative. So if it's me, okay, and given my age, I was exposed long ago, many decades, these numbers should be relatively low, 300, 350. They stay there forever, but they gradually decline on a slope. If it came back greater than 1,000 because it was so high they couldn't measure it, that's going to make me suspicious. All right, but it's a judgment call. I don't have gold standard proof. The gold standard proof is a test called a PCR that measures the DNA in the blood. So I do that test too. And most of the time, the PCR for EBV, the DNA for EBV, is negative, but these numbers are very high. And I say, well, that's walks like a duck and quacks like a duck. I think it's probably reactivation. All right? So then we need to make a decision on treatment. This is a whole another big piece of conversation.
But this stuff is fascinating to me, and neither one of us are immunologists, so I don't want to go too deep
or
in it.
Or virologists, for that matter.
Right, exactly.
Yeah.
But I've always been fascinated by this idea of memory cells and antibodies, and that this idea that these plasma cells are just secreting these antibodies, which were just produced supposedly because of memory, without any real trigger for their release, right? So then you have these antibodies floating around that are just thought to be due to remote exposure.
Right.
But I always question, well, but they're antibodies, they're proteins, so they have a half-life, so they're degraded by our bodies, but yet the plasma cells continue to just sort of secrete more.
They produce more. Why they?
But why? Why is the question? If there isn't further viral activity, right? Why?
Well, I mean, why?
I realize
it's an evolved mechanism in our immune system.
I was just going to say all that. I remember what the teaching was about it. It's really part of the surveillance of our body, of our immune surveillance, so that if we were to be exposed to this virus, we'd be poised to attack it. Right? I get it. I remember it very well. But every time I think beyond it, like as I've been doing since I've been doing this work, beyond what the teaching was, like into a deeper level, I can't help but come up with more questions than answers.
I agree. I mean, the other way to ask your question, or another way, is presumably the B cells, where the antibodies are made, have some program that lets them or tells them to make low levels of antibodies to EBV once you've been exposed for the rest of your life.
Right.
Okay. My question is, how does it know, that B cell, when instead of a protective level, it needs to do a spiked high level because now there's actual virus in the blood?
That's a great question.
It's an amazing miracle of our immune system.
Right.
But that's what I'm taking advantage of to determine or attempt to determine reactivation. So to do it another way, so this is the level.
Judgment call.
Yes, so this is the level, and then if I see numbers that appear to be a spike, I think that means that there must have been reactivation either at that moment or very recently, and that's why. And it generally works out based on response or progression of illness to be an accurate assessment, but it's not perfect, and most mainstream docs would say without a PCR you can't say that, so.
Right.
Okay, so there's four, up until recently, there's four routinely used oral antivirals for these herpes family infections, okay? Acyclovir, otherwise known as Zovirax, famciclovir, otherwise known as Famvir, Valacyclovir, Valtrex. They're all identical, virtually. It's the classic big pharma deal. They just change a little molecule so they can have a patent and make the same drug to the same thing. They're all very effective against herpes 1, herpes 2, genital herpes, and chickenpox virus, varicella. They are unpredictably effective against EBV. The fourth antiviral is valganciclovir or Valcyte. So Valcyte is remarkably effective against suppressing CMV, HHV6, and EBV. None of these drugs kill the virus. Okay, they just say go back to jail, be suppressed. The first three, as I said, are unpredictably effective against EBV, but in general, I will routinely begin with one of those because around half the time, it seems to me it works, even though it shouldn't be working, meaning that the EBV numbers start to come down, and there may be some perceived immediate benefit for the patient. They're less expensive, they have less side effects, and of course, a very important point, it's easier to get insurance to improve them. Hate to do medicine that way, but that's life, okay?
Sometimes we have to do what we
They're
do.
very well tolerated. Millions of people take any one of these three for their whole life. If they have genital herpes that recurs a lot, or if they have oral herpes HSV1 causing cold sores that recurs, they just take this as suppressive therapy for the rest of their life. Okay? If I'm treating a patient and I've monitored their labs, and now they suddenly get a positive PCR while on one of these drugs, and I usually use Valtrex as the easiest one to get through insurance, basically. Then that tells me this is not working for sure, and I will switch to Valcyte. Okay, Valcyte is a great drug. It's been around since the HIV days, so 25 years or so. I've had patients take Valcyte in the HIV days for years at a time for CMV. It's actually pretty well tolerated, but it does have more side effects. It can drop blood counts. It can raise liver enzymes. Recently generic, so it's not quite as expensive as it used to be, and it can be very effective. It probably has other benefits different from these three, and that's one of the things that's hinted in Montoya's study. Valcyte probably has anti-inflammatory properties, including in the brain. And so many patients will actually have significant benefit unrelated to its antiviral efficacy.
That applies to some of the antibiotics as well,
Right.
And it's always sort of a question of, whether it's the antimicrobial activity or the anti-inflammatory activity that is the reason behind the patient's, improvement.
Right. Unfortunately, that gets us into another controversy. That fact is often used by mainstream medicine and mainstream ID docs, infectious disease docs, to say, oh, you Lyme people are crazy. It's just the anti-inflammatory effect that's helping and has nothing to do with persistent Lyme disease.
Right.
That's another episode.
I have a lot to say about that, too.
Okay. So you choose a drug, and let's say I choose Valtrex. Let's just walk through a patient, for example. The next challenge, and I try
Dosing for Valtrex?
What was that?
What's your
it's
dosing?
1 gram 3 times a day.
Okay.
All right. Can cause headaches, and the blue coating on the pill sometimes causes mast cell activation.
What is that blue coating made out of?
Garbage. I don't know. Patients peel it off.
Okay.
Um,
No, that's good to know because I've
Right.
had patients report headaches. And
right. And in some ways, Famvir is a better choice, or maybe because we think it has a higher intracellular level,
Mm,
which is where you're trying to force the
right.
virus to go, so to speak. But it's more expensive, so I start with the Valtrex. So the next question that I would discuss with a patient, and I think is in this in the question the subscriber asked, is, well, then how do you know it's working? Okay, and that's a big challenging question.
And how
okay?
long do you wait to answer that question?
Right.
Like, how long do you? All right. Yeah. Sorry. Go
Okay,
ahead.
that's all right. So you'd think the easiest way to know is either the patient will feel better or their numbers will get better.
Mm-hmm.
Okay, so the problem is the patient doesn't necessarily feel badly in terms of a viral illness. They don't say, I have flu-like symptoms and a sore throat and my lymph nodes are big and I have low-grade fevers. They say, I feel like garbage, I have fatigue, I have post-exertional malaise, I have dysautonomia in POTS. So you don't. It's not like taking Paxlovid during acute COVID, where the patient in 36 hours says, often it's a miracle, I'm all better, it's gone. Okay, so you can't use that too well,
Right.
at least in the beginning. So then you say, well, what about the numbers? Can I look at those antibodies? So I mentioned 3 IgG levels. EBNA and VCA are sort of the long-acting memory antibodies, so they're not as useful, and they're not going to change rapidly. The early antigen is, we believe, positive in patients where there is clear-cut reactivation or recent infection. And therefore, ideally, it should respond by going down. The problem is it doesn't go down overnight. It's not like doing an HIV viral load or an EBV viral load where it's kind of a light switch. If it works, it's going to disappear. This could take months to go down. So it's a lagging indicator. So it's not easy to follow it. So in general, the decision that's made is patients will be on antiviral antiviral suppressive therapy. That's what we're doing. We're not killing anything for 3 to 6 months.
Okay.
And that's relatively arbitrary. Some of that comes out of Montoya's study, but it's something we've been doing for a long time now. And it's a little makes me anxious because I can't prove that people should be on it. And, understandably, most patients don't want to stay on drugs for a long period of time unless I can demonstrate that you need it and it's working.
But you've been doing this long enough. Have you found that
I think I do think it works.
Yeah. So obviously.
Yeah.
Yeah.
And most people tolerate it very well. But it can be a lot of pills.
Right.
They tolerate it. And I do safety labs. So safety labs generally mean a CBC and a complete metabolic panel. Even though these the first 3 have minimal blood chemistry toxicity, I still follow at least after the first month and then maybe after 2 or 3 months, whereas Valsite I usually require monthly safety labs. Okay, with Valsite, it can lower blood counts, it can raise liver enzymes, neither of which I've ever seen as a significant problem, and it can cause depression in around 5% or less of people, which can be very significant. So you really have to tell the patient and warn them about that. Many patients will feel worse before they feel better with Valsite. It's like a quote die-off, but of course it's not a die-off, but that's how it's easier for people to think of it that way. I'm not sure what that is. It's probably not. It's probably the opposite of a die-off. It's probably a cytokine flare as the body kicks into gear with the help of the Valsite to suppress the virus. Some patients just can't stand it. It's a small minority, but they just feel sick with it and they stop. But generally very well tolerated. I want to give a patient example in terms of how do you know that it works, okay? So I have a patient that I've now taken care of for 10 or 11 years. Lovely, lovely older woman, about 70 years old now. Came to me 10 years ago. So she had terrible brain fog. And on her labs, her CMV immunoglobulin levels were very high. They were greater than the limit of measurement. But that doesn't mean she has reactivation. Her DNA, her PCR DNA was negative. I put her on Valsite finally, and her brain fog cleared completely, and she felt remarkably better.
And no other medications, just Valsite.
No, she was on other meds, but it was the Valsite. Well,
Okay.
I'll show you why it was the Valsite.
Okay.
I mean, she was on meds for, she didn't really have POTS. She had adrenal insufficiency also, so she was on hydrocortisone. So after 6 months, I said, you're doing great. I think we should taper and stop the Valsite. So we did that. Came back the next month, brain fog's all back. Okay. Restart the Valsite, all gone. And this has gone on now like 3 or 4 times. I just had another appointment with her the other day because she had, in the previous appointment, she said, my memory's bad again. I'm having trouble. And, I have all these family events happening. I'm really excited, but I can't even think straight. Put her back on Valsite. I saw her literally this week. Memory's back to normal. Her brain fog's gone. So I'm just going to give up and just keep her on Valsite the rest of her life. But to me, a perfect example of how unclear the situation is.
Yeah.
I mean, unfortunately, it's like you're flying a plane in the fog, and we don't really have instruments. We only have 1 or 2 instruments that work.
For sure.
And you need to make judgments, and again, that judgment is driven by an understanding and a accounting for the risk versus the benefit.
Well, it's an educated judgment for sure. I mean, obviously, I think all the judgments that we make and all the decisions that we make come from some form of an educated theoretical basis. Right. It also can be, of course, clouded by your the last patient experience or your example,
absolutely.
right? So you'll forever think about
this. Fancy name for that. Bias. Like there's a big word in logistics for that, or philosophy. I forgot. Anyhow.
I'm sure there is, because it makes sense, right?
Yeah.
I'll always remember some response by a patient to a particular drug, and then I'll always think of that drug for that same symptom in other patients.
Right.
And you don't always have that profound kind of response, like with this patient you just described, right?
So I would add that, based on everything you just said and what I was describing, is given the reasonable safety and low adverse effect status of these drugs, I would argue once again it's a trial and error situation. If I'm getting nowhere with a patient and I don't have a lot of evidence, I'll just try an antiviral.
Yeah.
And sometimes it works and they start to feel better, and sometimes it doesn't. It's unfortunately part of what we have to do.
Do you do the same with antibiotics?
In terms of trials? I don't, unless I have a strong reason to think about doing it.
Okay.
In other words, if let's say somebody's mycoplasma, which is a bacteria, mycoplasma IgM is high, that is a no-no. That's not supposed to happen. I guess this really isn't answering your question, because that, to me, it's a no-brainer. Of course I would give them antibiotics. You're asking me, do I have somebody who's not getting better? I don't have any evidence of infection.
That wasn't what my question was, but the IgM mycoplasma is an interesting example that you brought up, because we see that regularly. And I've actually asked infectious disease doctors, what's this about? I mean, even though they don't have any symptoms of a pneumonia or anything like that, and they always just say that it's nothing to ignore it, that it's probably some sort of mimicry in action, right?
Yeah, I don't agree.
But yet I see IgM elevations in mycoplasma all the time.
That's why I look for it with every patient.
Right, exactly.
I mean, my new patient screen, maybe this is relevant to this conversation, is all of the serology means antibody testing. So all of the serology for the herpes family viruses. I don't do herpes 8, which is Kaposi's sarcoma, because I don't think it's relevant to our patients. But I do the others. 7 is a little hard to get, so I don't always do it. And I now routinely, as part of my first visit new patient panel, do EBV PCR because I've had so many times now where the early antigen is negative and the PCR is positive, which flies in the face of everything I just said about early antigen. And don't ask me to explain it. I can't. But I've seen it over and over now, so I don't wait. I just do it. And then I do mycoplasma IgG and IgM, and chlamydia pneumonia, not the STD chlamydia, IgG and IgM. And the reason for those two specifically is that they're kind of stealth bacteria. They can be intracellular, and they can cause autoimmune problems as well. And then I always do ASO and DNase for strep because of the whole world of autoimmune encephalopathy, which we'll get into at another time.
So you do that whole workup?
Yeah, that's part of my initial workup.
I haven't been doing that kind of workup initially.
Maybe that's an episode we should do on like initial initial
Well, that would
workup.
actually answer we have a subscriber who's a PCP who's very interested in sort of what the initial workup should
That'd be a great episode.
Okay.
Initial
we could
workup,
sort of like
initial tests,
right.
diagnostic tests, and maybe initial considerations for treatment in that first visit.
Right. Well, we can do that a little bit now with regards to just infectious pathogens.
Yeah, but I think it'd be better to do it together. So I answered your question again. I'm not as loose with antibiotics, so to speak, because I think there's more potential for problems in terms of microbiome,
right,
and just general GI adverse effects.
Do you use a lot of minocycline?
I don't, because I have a lot of patients get dizzy whenever I give it to them.
Yeah.
But it's a great anti-inflammatory.
Right. It also has been implicated in intracranial hypertension.
Causing it.
Yeah.
Yeah.
So.
Another reason not to stay away from it.
I've just had a lot of patients come in and they've been put on minocycline by other doctors.
For anti-inflammation or for infection? I'm just checking the question list and see if I covered most.
No, I think for both, actually. It's I think a lot of alternative providers seem to really like minocycline. And so I'm always taking patients off of it. And listening to you, I'm wondering maybe I should just keep them on it.
Well,
I mean, first I'll ask if they think that it provided any benefit.
Yeah, I mean, I always ask that question.
No.
Do you think it's helped or not?
And they usually say, I don't know.
Yeah. So let me see if I did this. Which antivirals do you like? I'm going to come back to that because there's some more to say there. How long do you treat? I said that, right?
Mm-hmm.
Labs. I talked about that. CBC and metabolic panel. Okay, 3 to 6 months. Okay, so let me just talk more about specific drugs. Mm. So those are the four that I mentioned, right? Famvir, Valtrex, acyclovir, Valsite. Those are the generic brand names. Recently, it's been shown that an old, I can't believe I called this old, HIV drug called tenofovir, which was, I think, came out in late 90s, has EBV efficacy. So I've been switching many patients to tenofovir.
What's the brand name?
Viriad.
Viriad.
Okay. And the reason I'm switching is, one, it's totally cheap now because it's so old. Still amazing. It's 1 pill a day. It's got almost zero side effects, sometimes some renal kidney function problems. And so far, it's been working. I just had another patient this week. I'm making this up. And he'd been on Valtrex and Valsite, and his EBV was positive. PCR was positive. I switched him to tenofovir, and it's negative now.
Wow.
Important to underline, there's no change in how he feels yet. Okay. I mean, I really
but that can lag, right?
Right. So tenofovir, it's a really great drug. And then this subscriber asked about Maraviroc. So Maraviroc is another HIV drug from the 2000s, I think. Totally fascinating drug from an HIV perspective. Mm-hmm. I could talk about that for an hour, but it has nothing to do with this.
But it's been used for COVID.
Right. So it's being offered or suggested to use in COVID because Patterson, a Stanford guy, and his group, FLCCC, believes that it helps reduce inflammatory markers that are present in long COVID patients. Mm-hmm. I've been less impressed. I have not seen much benefit from it. But it really does make me think that we have this world of antiviral drugs that we probably should be playing around with more and using for off-label indications to see, because that's how you learn. You know?
I completely agree. And I was just having this conversation about antihistamines even. I mean, antihistamines have been on the market for decades.
Right.
And I don't know if it's just big pharma and these big pharmaceutical companies that are, bring on these new ones in the market, make them over the counter, and it's like in the marketing world, there are names for these kinds of things. But when you associate the name of a, it's like Pampers. Like you can't help it. Those are diapers.
Right.
But we refer to them as Pampers. Kleenex, perfect another example. And so like Claritin and Allegra and, all Zyrtec and Zantac, they've all got that kind of, correlation now.
Brand imprint.
Brand imprint, right, exactly. Clearly I'm not a marketing expert. But I think back to all the antihistamines that have always been on the market that are now generic, most of them you need a prescription for. They're not over the counter, hence they don't have this big marketing, stuff behind them, but are in my experience recently, are more effective than some of these over-the-counter ones, and
Oh yeah.
and interesting to use, and especially with all our mast cell patients.
And as you're about to say, probably we have, by using them, we've discovered they have other efficacy.
That's
other
where I was going.
actions
Absolutely.
that we never would have considered.
Absolutely. That is what I'm finding. And it's largely because I was, as I've said in another episode, I use a lot of cyproheptadine. We use it in neurology all the time, especially in pediatric neurology. We treat pediatric migraines with cyproheptadine. We use it for lots of other reasons. And so I started using that for a lot of my MCAS patients just because I was familiar with it and comfortable with it. And I was finding that there was a lot of other benefits to it, including things like brain fog, by the way, including things like sleep, which most antihistamines will help. But and then there were other, like improved pain.
Yeah, I think Lenny Weinstock says it helps with gut motility.
It does help with gut motility for
thought?
sure, because pediatric migraines are mainly in the gut, right? So this is why we use cyproheptadine. So the fact that we use it in young kids, frankly, I always felt it was safe. I always knew it was tolerated. I used it at Children's Hospital all the time. Similarly with hydroxyzine. So these are obviously not unknown and, obscure ones, but ones that I've been using that have not been on the forefront of MCAS treatments. But then I started to think about what about the generations before those, right? And so I was doing some research and I found some others that I started to try to use. They turned out to be somewhat difficult to come by, a lot more expensive than I thought they would be, largely because they're not that available. So pharmacists have to go order it, special supply, and regardless. So there's like a whole supply issue with it. But it just does bring me to the thought of like we should be looking back at some of the older drugs that were used for one indication, maybe 30 years ago, and sort of see how we can repackage that and use that for newer indications, because they have been around for a long time, which means that we know a lot about them.
Right.
Which means we know a lot about side effects, we know a lot about mechanism of action, we know a lot about, other kinds of interactions with other kinds of drugs, tolerance. So I feel like we need to sort of start thinking outside the box a little bit. And so I agree, some of these older drugs really are showing great use in our patient population. And I think that within them, we can find things that are a lot more effective than what we have been using.
Yeah, no, I agree.
So,
completely agree. What's the brand name? What was the brand name for cyproheptadine?
Periactin.
Periactin, that's it.
Which is a weird name.
I know. And I blocked it out for that reason. Periactin. Okay. I agree. And I like we said, I think it's relevant to antivirals because maybe we should be trying. Maybe we should be trying some of the other HIV antiviral drugs.
Yeah, absolutely.
HIV disease exploded the world of drug development in a very positive way.
Specifically an antiviral. Yeah.
So it may make sense to try them, juggling risk and benefit.
I completely agree. I think you should go back to your HIV days and sort of see what you can pull out of that treasure trove.
I want to emphasize that for long COVID, everything I've been saying applies. I've seen probably a third of my long COVID patients have had positive EBV PCRs, meaning they have circulating DNA. They're viremic, which is not kosher, right? That means that the virus has reactivated. And whether the EBV viremia is driving their long COVID symptoms, I'm not saying I know. I don't know, but it doesn't mean we should ignore it, And I think it's an example of how crucial the whole reactivation issue is. And it's probably true in lots of other illnesses where it's never looked at. I bet if you went into an ICU at UW and took 30 patients in the ICU on ventilators and 50% who are not doing well, and drew PCRs, you probably get, a third of them are positive. And they're not on antivirals.
And think about all the viruses we don't even know exist.
Right.
I mean, that's what's terrifying to me. I mean, we're looking for the ones we know about. What about the ones we don't know about?
No, that's true. Very true.
Right.
And that does come up. I mean, I've had patients who describe a clear infectious encounter, meaning with a person, next day they feel sick, and then they go on to develop a strange illness. And I've run viral serologies on every virus I can think of, all negative, but there's just almost no question they have it. How do you look for something when you don't have a test for it?
No, absolutely.
It's like autoantibodies,
Right. Well, I think that when you do the PCR, though, I think they've found genomes that they couldn't identify what virus it came from.
Right.
So clearly there are things out there that are lurking.
Right. So I probably getting near the end, but I think one of the messages here for our patients and subscribers and physicians, is many physicians are going to be very uncomfortable with what we've just been talking about.
So I guess a good question is, other than the antivirals, is there any other approach that you use in terms of class of medications for viruses? I mean, that
You
sounds
mean
like a ridiculous
treatment-wise?
question the way it came out, but I realize,
Treatment-wise?
yeah, treatment-wise. I mean, so let's say a patient is dead set, doesn't want any antivirals. Like, is there
Let me
any other
answer
way
in a
that you
second.
can
Let me
you can
just finish
treat?
what I was going to,
Oh,
my
okay,
little
sorry.
speech there for a second. I'm sorry.
you-
That's okay. So what I was going to say was, many physicians are not going to be comfortable prescribing an antiviral, one, because they think an antiviral is a big deal,
Right.
and two, they don't feel they have enough evidence to do it. And the argument here is, they have no problem giving azithromycin for a sore throat with no culture even done.
Right.
So why can't you take that logic and apply it to our patients where there's so much evidence that they may have viral activity, viral reactivation, and the drugs are equally benign? I would argue they're just as benign as azithromycin.
It's a great argument.
So, okay. Your question was...
I'm just wondering if there's anything other than direct antiviral.
So
drugs.
anything I can think of to enhance the competency of the patient's immune system,
Okay.
I will do. Problem is there aren't a lot of interventions. My favorite intervention has been conveniently or inconveniently banned by the FDA, and that's thymosin alpha-1.
Mm-hmm.
TA1 is well proven.
Yeah.
It's actually an approved goddamn drug. It's
know.
approved for hepatitis, but it's not available in this country. It's the craziest thing. So they compound it for injection, and then the FDA has blocked it and said you can't do that. It is a proven antiviral drug. It is proven to increase NK cell function,
Mm-hmm.
which is deficient in
Yes.
every single ME/CFS patient. Okay, and therefore it improves immune competence. So that was my go-to.
And that is a peptide.
It's a peptide.
What about LL37 as a peptide?
I've tried it a few times. Haven't used it as much.
Okay.
Maybe I should be using it much more.
Yeah.
Nutrition.
Right. So
All the
even-
usual sort of the things your grandma told you about being healthy for your immune system, all true.
all true.
And so I'll discuss that.
Isn't it amazing that there are so many more drugs that suppress and compromise the immune function,
Right.
but very few, if really any, that boost it?
Right. Well, that we know of. I'm sure
Right.
there are. LDN, I think, is relevant to that because it modulates the immune system, low-dose
Right.
naltrexone. So I think that can be beneficial. I think exosomes, which we'll talk about in another show or another episode, improve immune competence while reducing
Absolutely.
autoimmunity, so immune modulator. IVIG, of course, is an immune modulator. Very expensive, hard to get approved.
Speaking of LDN, there was that question about how long you would wait to see if it's efficacious for the patient.
Oh, right. So I don't know what you do. What I do is assuming there's no side effects, once they're at the target level, which is usually 4.5 milligrams, ask them to give it at least 3 months, preferably 6 months. The truth is most of my patients find benefit within a month to 6 weeks.
I agree with that. It's usually within a month. It's usually when they're at least a minimal therapeutic dose, even though I start low and titrate slow.
Right.
I often don't have to go up to 4.5. Usually at around 3 seems to be
Yeah.
a sweet spot for many patients, not all. If they have to go to 4.5, I find that there's less of a chance it's going to be that beneficial for them. I have seen some doctors go up to 6. I have not yet done that. The truth is, speaking of that, is that for my patients who have chronic pain syndromes in the realm of CRPS, I've actually just started using naltrexone, like 25 or 50 milligrams.
Really?
Yes, because the mechanism of action also includes reducing the reduction of microglial activation. So I find that with that kind of anti-neuroinflammatory effect, it really helps a lot of patients in that CRPS realm.
Wow.
So not chronic
that's
pain
really
in the terms
interesting.
of like my knee has been hurting for 40 years,
Right.
more of like I can't find a reason for this level of severe pain that has been so chronic. And so I think of it as a neuroinflammatory response, which is altering the pain pathways. And so I've just gone to naltrexone.
So in those higher doses, it's also microglial anti-inflammatory?
Mm-hmm. At those higher doses is when it's most effective at that.
Didn't know that. Very interesting. So I do tend to go to the target of 4.5, and in particularly patients who have pain, I will go higher with benefit.
Yeah.
And or I will split the dose.
Right. So for neuropathic pain, for sure, the low dose naltrexone has been
Right.
very effective.
Right.
Very effective.
And it helps brain fog. No, I mean, at the
Definitely
lower
helps brain
dose,
fog.
even though you're saying
Yeah.
the higher dose is more anti-inflammatory, the low dose really clears brain fog for a substantial number of patients.
Yeah, I think it's a great drug. And speaking of antivirals, going back a step a little bit, amantadine has also been very helpful, and I think I mentioned that to you for brain fog for my patients.
Right.
And that's also been an antiviral, but it's also and in fact, it's been used, in the pediatric spectrum world. We've used it. It improves communication in children with spectrum disorders who have difficulty with communication. It actually improves that aspect of their disorder. There's a reduction of neuroinflammation. So I've used amantadine, but that's also it's classified as an antiviral. So that's another possible drug. Yeah, for the flu, right? And it's also it affects dopamine levels and dopamine function.
I'm still fascinated by what you said with naltrexone. I already have a patient I have to call. Wow, that's amazing.
Yeah. So anyway, that's my point about these medications is that, sometimes you have to sort of rethink, even though we're already outside the box, and even though we have already spent a career second guessing everything that we learned, I think you have to continually do that. Even when you've second guessed it and you've changed your ways, you have to, at some points along the way, sort of revisit now how you've changed those ways.
Absolutely.
And sort of see where you
that's
go
the
from
beauty
there.
of us talking.
Oh, absolutely.
And of our Masterminds listserv, because now you have 400 brains saying, oh, I tried this, and you know what, it worked. Or
there's good and bad to
well, there's good and bad,
brains.
but there's still a lot to learn. And I think that it potentially speeds the knowledge acquisition of doing things in new and
I agree with that.
Unknown ways.
What it does is it makes me, even though I might disagree with someone's post, it does give me pause for thought.
Right.
It does make me think a little bit harder about what I believe to be true and what I'm doing for patients. It makes me consider other aspects and other people's opinions. Yeah. It doesn't always change what I do.
No, I'm not saying it does.
But occasionally I sort of think, is there something to this person's post?
Right.
Yeah.
So other immune boosting things, we said LDN exosomes. So stem cells, of course.
Mm-hmm.
And my latest favorite, rapamycin.
Oh, yeah.
Okay.
Speaking of things that have been around for a long time.
Right, exactly. So there are many interventions, there's no question.
Yes, for sure. And I think all of those are within the realm of like regeneration, which is why they're in the longevity world. And again, we say this every time. We should just do it the next episode, talk about these things.
Right.
But I think play a really important role in our patient population. I have no doubt. I see it, as do you, and we should talk about it.
Yep.
But this was a really good conversation. I learned a lot.
Good. Yeah, it's a favorite topic of mine.
Bring on the viruses.
Favorite topic. Okay, well, thank you very much. I hope I didn't confuse people and we didn't talk too fast.
I think you were very clear.
Okay, good.
I think going through a patient case example was actually very helpful.
Yeah.
So thanks for joining us, and we will see you next time. Bye.
Bye.